So, for today's presentation, I'm going to be discussing sexual variations. So, what are sexual variations? They are, as described by NCBI, a neutral term for behaviors formerly called deviant. They can be defined as conditions in which a person's sexual gratification is dependent on an unusual sexual experience revolving around particular sex objects. This article also relays that variations are much more common in men than they are in women. It's apparent that as a society, we're working hard on de-vilifying sexual variations. In this presentation, you may recognize some variations that may have no bearing on a person's judgment, rationale, or intent. However, most variations listed here should require proper treatment and rehabilitation. In pathologizing sexual deviance, the text recalls how deviance was formally classified. It states, pathological anatomists before the 19th century saw sexual perversions as diseases of the genitals, caused by an anatomical abnormality therein. The psychology behind this has clearly evolved since this time. Treatment for sexual variations has waxed and waned for the last century and a half. After psychology has started becoming widely appreciated and staked some authority in medical treatment, the theories have evolved significantly. For example, an early psychologist, Johann Heinroth, theorized that people who suffered from mental disorders, including those with sexual variations, were responsible for abandoning their inhibitions. Therefore, they were culpable of the sexual crimes they committed. According to pathologizing sexual deviance, this ideology was quickly abandoned. Throughout this presentation, we'll discuss different categories of sexual variations, the history associated with them, and the current treatments, if any are warranted. According to NCBI, fetishism involves recurrent sexual urges or behaviors concerning the use of inanimate objects such as leather and rubber garments, women's underwear, stockings, and shoes and boots. Within the psychological world, this is a fairly controversial topic. Some firmly believe that eradicating a fetish isn't just possible, but the ethics of it are strongly called into question. On the other hand, many believe that it's quite possible and potentially beneficial. One psychologist, whose name has been redacted from this article, maintains that it is possible and theorizes that, I don't see a fetish as similar to sexual orientation. It is something that does reflect that something is wrong. This therapist continued to describe his treatment. He employed cognitive negative conditioning. Initially, this involves smelling off-putting aromas in order to reduce the fetishistic practices. After a negative experience with this particular practice, this therapist discontinued the use of conditioning with aromas and stuck with strict talk therapy. For some historical context, there was a study conducted in 1974 regarding treating a patient for fetishistic behaviors. The subject was a 21-year-old male who had become sexually aroused by trousers. The patient got along well socially with peers and with women. He opted for treatment to dispel his sexual attraction to trousers. The subject brought along some of his trouser collection, and he was punished at various points in the behavior series involved in reaching for the trousers, picking them up, feeling them, smelling them, and placing the trousers against his body. The punishment employed was either an electrical shock or a command administered by the therapist. The results directly following the treatment was positive in terms of the goal. However, the ideal goal was to eradicate the fetish altogether. In turn, they employed smelling salts. If the patient had sexual urges caused by the trousers, he was to smell the salts. This utilization further improved the results of the treatment. It appears that cognitive negative conditioning is the road most traveled. I'm not qualified to speak to the ethics of this practice. It's my opinion that if a patient seeks help to curb tendencies that they find troublesome or that inhibit normal daily activities, it's up to them to choose and follow a treatment program. According to NCBI, exhibitionism is among the most common of the sexual variations. The usual image is of a middle-aged man in a dirty raincoat flashing. Typically, however, exhibitionists are postpubescent males up to the age of 40 who obtain high levels of sexual pleasure and excitement from exposing their genitals to females, usually strangers, and who may masturbate at the same time. According to Psychology Today's article Exhibitionism, this disorder affects approximately 2 to 4% of the male population. In order to meet the classification of exhibitionism, the DSM-5 states that over a period of at least 6 months, a person has recurrent and intense sexual arousing fantasies, behaviors, or urges that involve exposing the genitals to an unsuspecting person. And the person has acted on these sexual urges with a non-consenting person, or the urges or fantasies cause marked distress or interpersonal difficulties in the workplace or in everyday social situations. Cognitive behavioral therapy is most often employed in treating someone who suffers from this disorder. Additionally, this article also relays relaxation training, empathy training, coping skills training, and cognitive restructuring can aid in curbing the urges and behaviors. Abnormal psychology best describes voyeurism as an individual that has recurrent, intense, sexually arousing fantasies, urges, or behaviors involving the observation of unsuspecting females who are undressing or of couples engaging in sexual activity. Frequently, such individuals masturbate during their peeping activity. The DSM-5's criteria for voyeurism classification is as follows. The individual must exhibit behaviors over a period of at least 6 months, recurrent and intense sexual arousal from observing an unsuspecting person who is naked, in the process of disrobing, or engaging in sexual activity, as manifested by fantasies, urges, or behaviors. Additionally, the individual has acted on these urges with a non-consenting person, or the sexual urges or fantasies cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. Also, the individual experiencing the arousal and or acting on the urges is at least 18 years of age. In addition to this, the Merck Manual states that most people who have voyeuristic tendencies do not necessarily have voyeuristic disorder. I think this is an important distinction to recognize and appreciate. The treatment for voyeuristic disorder is psychotherapy, support groups, and in some cases, antidepressants. I thought it might be interesting to see how things have changed regarding the ease of looking in on people in the digital age. According to Wendy L. Patrick, in the digital age, why voyeurs prefer to spy in person, there is still a heavy preference for a personal invasion of privacy versus a digital one. BDSM has become a hot-button talking point in the last few years. The 50 Shades of Grey series made some noise and opened up a serious conversation. My best friend even had a lot of contention within her own family regarding her decision to read the books. While I'm of the personal opinion that this is an appropriate way to exercise sexual exploration and freedom, I do think it's important to touch on the DSM-5's classification specifically for sadism and masochism. The practices are different, and there must be a clear dichotomy between appropriate consenting behavior and dangerous non-consensual behavior. Sadism disorder must be seen over a period of at least 6 months, recurrent and intense sexual arousal from the physical or psychological suffering of another person, as manifested by fantasies, urges, or behaviors. Also, the individual must have acted on these sexual urges with a non-consenting person, or the sexual urges or fantasies cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. The DSM-5's classification for masochism are as follows. A person must be experiencing recurrent and intense sexual arousal from the act of being humiliated, beaten, bound, or otherwise made to suffer, as manifested by fantasies, urges, or behaviors for at least 6 months. The fantasies, urges, or behaviors cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. The treatment for both sadism and masochism sexual disorders involve psychotherapy, and in some cases, antidepressants. NCBI reports in the new DSM-5, pedophilia is depathologized by differentiating between the sexual preference for prepubescent children and the disorder in case of additional factors. These factors include experiencing significant distress and impairment by fantasies and urges or the acting out on behavioral level, including child pornography consumption and/or committing hands-on CSA offenses. Pedophilia is being very closely examined due to the dangers of the action. In research, the Tanner stages are often usefully employed to help determine preference in convicted offenders. Utilizing the Tanner stages, a proven research method often employed in the 1960s, was measuring a relative change in penile response to various classes of sexual stimuli. More recently, in a study conducted in 2012, eye tracking and pupil monitoring was used to examine preference. 35 men, 24 were heterosexual and 11 were homosexual, with no history of child abuse offenses, participated in this study. The stimuli used was female only. There was an indication that there was a preference for gender, but there was no indication in age preference. This method of eye tracking has not yet been used specifically to identify pedophilia. Comorbidities are often associated with pedophilia. NCBI reports men with pedophilia often have extensive histories of psychiatric disorders that, in extreme cases, can overshadow discovery of etiological course. Whether this is a secondary phenomenon that relates to emotional and social consequences of this preference, or whether these are true comorbidities, remains elusive. NCBI also reports that there is a direct correlation between IQ and sexual offenders. Furthermore, the lower the IQ, the younger the victim of the perpetrator. It's also been shown that there's a link between in utero testosterone development and sexual preferences. Though not concrete, NCBI relays, however, the onset of these differences is in utero, childhood, and adolescence, thus suggesting that these findings are actually a part of human development and contribute to pedophilic preference onset rather than acting as a consequence thereof. Additionally, men incarcerated for acting on pedophilic urges had sustained twice the amount of head injuries before the age of 13 than men who did not have pedophilic tendencies. In 2007, neuroimaging was used with the intention of finding correlations between irregularities and pedophilia. Though the study was not conclusive, there was an interesting case found with relevant findings. A 40-year-old man was diagnosed with an orbitofrontal tumor with no prior pedophilic tendencies, had made sexual advances toward his stepdaughter. Additionally, he had begun collecting child pornography. After the tumor was resected, the tendencies had disappeared. The tumor reemerged and so did the pedophilia. After the second resection, the side effects subsided once again. In terms of treatment, cognitive behavioral therapy, or CBT, and drug therapy are often used. It's been shown that antidepressant medications used to treat OCD show some improvement. And here are my references. If you guys have any questions, go ahead and shoot me a message.